I'm going to concentrate on genomics first and then machine learning and AI. So obviously genomics is another subject which has been given a greater profile during the pandemic. For example, the investigations by UK Genomics of the genetic susceptibility to COVID-19. Once you've taken the age of the person, their sex, which we know are two, and comorbidities, which we know are very important factors in risk of severe consequences of being infected by the virus. Once you take those into account, then it is quite clear that differences, particular gene mutations in certain individuals, may make them more susceptible to having really serious outcomes as a result of becoming infected. So do you think that this might help the public have a greater acceptance of genomics? Because we discussed this on the Topol Review. Obviously, families where there was a genetic mutation which make them susceptible to particular conditions and so on were very well aware of genomics, but the general public was far less aware and probably in many ways resistant to this newfangled subject. So I'm going to ask Rose and then Elizabeth and maybe Henrietta to comment on that, please. Oh, sorry, I didn't mean Rose. I meant Berne.
Okay.
So Berne first, and then Elizabeth and Henrietta.
Yeah, I think this is a really interesting question, and my answer would be definitely it has. I think that the genomics and actually all of the other sciences that genomics actually is part of, such as microbiology, immunology, biochemistry, they have been catapulted into people's vocabulary, and they weren't before. And I think that the public, and I also think patients, there's a number of things I'd say about them. First of all, is I think that they're much less afraid now of genomics. I think they were afraid of genomics, and they were afraid really of science. But I think that, and a little bit wary of scientists. I think they're still a bit wary of scientists, but I believe that there's more of a trust now. And I think that that's a huge positive thing that's come out of COVID. And I think it's driven that kind of genomics agenda that we highlighted in Topol. It's driven it much quicker than it ever could have been before. So I think that they're less afraid of it. Not only that, that they're much more, they've been educated because there's been no choice but to have to educate them, because this virus, because this virus mutates such a lot, and these different strains, people now are really caused by genetic mutations. The general public are beginning to understand this. They're not just beginning to understand, Lionel, what I think, what you were saying in terms of their own susceptibility, but they're beginning to understand that genomics and genetics is everywhere. That this virus is changing all the time, and actually that's a big deal. We have to know about that. So I think that they're appreciating that kind of. They're appreciating that genomics is everywhere, not just in their own susceptibility to disease, but the diseases themselves can change. So I think there's a much greater trust. I think they understand that genomics is the basis of all the testing. And it's really funny now in everybody's conversation, people will be chatting over a cup of tea and talking about the PCR test. And they didn't know about that. Nobody would have known what a PCR test was. And now this is coming and people chat about it. And, they're also aware that all of the vaccines are dependent on genomics and an understanding of genomics. So I think it's going to be very interesting to see how. I don't think this is going to go away. I mean, if I speak to colleagues and if I just speak to friends who are not scientists, they're genuinely much more interested now in understanding what genomics is and well, they now know it affects their lives. And I think with it's been so clear during this pandemic that that this virus, as you said, is not equal. It's not affecting people equally. You know, we've seen that people of different ethnicities are really affected, and now people understand that that has something to do with their genes. And I think that's a really, in terms of people becoming less afraid and more accepting of genomics, and more accepting of like personalized medicine, that's a really positive thing, because they now want to understand, well, what is it about me? What is it about my genes that are making me much more susceptible? I really want to know about that. And it's not only the public that have become much more understanding of genomics, but all of the NHS professionals in the whole of the NHS, they now understand that they have to understand this. So I think that we're now going to be pushing an open door to get nurses to take up courses in genetics, to get pharmacists to take up courses in genetics, engineers. They have to understand genetics now. So I think, all in all, I think that the pandemic, as somebody said, well, it's been awful in many ways. In terms of the agenda for Topol and genomics particularly, has actually, it's just opened it up now and made people much less afraid of it, which would have taken us years to do.
Thanks very much, Bernie. Elizabeth.
Yes, I would agree with all of that. I mean, we've all been taught that genomics is a lifesaver for us. So I think it's acquired a new profile. It's acquired much more respect and much more trust. But I think when you just step out of the COVID scenario for a moment and think about how it feels as a patient to be offered the opportunity to find out that you may have genetic susceptibility to some horrible disease you'd really rather not know about. So I think the question that we've still got to answer is the so what question. Leaving outside COVID, for genomics to reach its full potential with patients, we have to confront that ethical dilemma of, just because we can tell somebody something, that we may not be able to help them as much as we would like with. Should we be telling them that? And will they want to know that? We haven't answered that question because we haven't needed to, because COVID has taken over for us. But when COVID is gone, I think we have to confront that one.
Absolutely. Absolutely.
Bernie, do you want to comment briefly before Henrietta comes in?
Yeah, I do. I think that the aspect of the ethical, I would not disagree with you at all, Elizabeth. I think that that's very true. And I think that is the kind of the ethical dilemma of wanting to know whether or not you are going to be susceptible to a life-threatening or a terminal disease is something that is going to be very tricky to understand. I completely agree. But again, on a more positive side after COVID, I think that what this has shown is, as I said earlier, I think it's shown that how we are genetically made up is going to affect our response, not just to terminal illnesses, but to all illnesses, to how we respond to all sorts of different viruses and bacteria or fungi, any kind of microorganisms that might affect us. And I think people will be much more believing that, you know, lifestyle and environmental things will also affect your genes. So it's not in any way disagreeing with you, but just saying, I think that I suppose what I'm saying is I think there's still a very huge positive effect that's come out of COVID that has just bypassed 10, 15, 20 years that we otherwise would have to have been trying to advocate for to many deaf ears.
Thank you very much, Bernie. I'm going to leave the last word on this topic to Henrietta.
Yeah, no, I am dying to come in, but not to put a damper on the conversation. But I think it's, I mean, Bernie, you've highlighted some really key points. And yes, overall, in terms of our population understanding genomics or genetics and implications for susceptibility and all of that, great. But for me, I think what needs to be addressed is the targeted education, or looking at it from different perspectives. Because if we look at all the discussions around the COVID and how it's impacted on people from BAME communities, for me, the difficulty is they're not entirely interpreting all of that data or information to links with genetics. Some of it is highlighting for a lot of these communities the other socioeconomic factors, which seems to be taking over the genetic aspect of it.
Yeah.
So I think whilst we are doing all of this, and obviously patient and citizens education was key to all the discussions in the Topol Review, we really need to think about the so what after COVID-19 and how we begin to have these communications with those communities to really understand the fundamental driver in all of this. And yes, there are socioeconomic factors, but equally there is the genetic factor that cannot be ignored. And hence, I mean, we are beginning to see again how it's translating for vaccinations. If they have understood it as genetic related, people will be at the front of the queue for vaccinations, but we are not seeing that.
Yes, I agree with you, and I don't want to take up any more time, but we've seen that in trainees and students who've set up BME groups, partly since George Floyd and partly since COVID has started. And that's very true. When we've addressed this issue about why is it that the people from the BAME backgrounds are more susceptible, they've not wanted to think about the genetic proclivities of that. They've all said it's just to do that's, and the genetics is very minor. That is a problem, Henrietta. I completely agree with you.
Okay, well, thank you very much. For the last 10 minutes or so, I would like to focus on AI and machine learning. And at the time of the Topol Review, there were plenty of research papers about analyzing databases of patient data with various algorithms. So really on clinical data, but the big difference now that the pandemic has made is, which wasn't really foreseen at the time that we wrote the Topol report, that it would happen so fast, is that actually some of these algorithms have now been authorized by the regulators for use in hospitals and other aspects of healthcare. So that was thought to be on a 5 to 10 year time scale. It's now happened. For example, the FDA, and the MHR is not far behind, has approved the use using the emergency use authorization procedure of algorithms for patient stratification within the ICU, or for example, if you look at the patients coming into A&E, how many ICU beds are likely to be required in the next 24 hours or so. And these are now being used in various hospitals, certainly in the US and in the UK as well. So a real transformation from a research topic that was obviously had great application to healthcare to something which is now actually in clinical use today. So I wanted to ask Rose whether you think this is something that's here to stay, or it was just a spike to do with the pandemic, or do you think this accelerated use of machine learning and it's principally machine learning algorithms during the pandemic is here to stay? And what is the impact then on the workforce in terms of training for the potential utilization, interpretation of these algorithms? Over to you.
Absolutely. Thank you, Lionel. And to a less extreme extent to the genomics that Berne talked about, I don't think people are talking about machine learning over a cup of coffee, although maybe they are, or maybe I'm wrong. But I definitely think that the fact that these tools are being used in an as you say, the use of them has been accelerated, and they're proving very useful in this really quite desperate situation, particularly with hospitals being overwhelmed. So that's a real win. I completely agree with you. And I don't think that will be forgotten. However, I think the core, when we were looking at AI and robotics, one of the things we were thinking about in terms of training is the need for everybody to understand enough about data and the role that data plays in machine learning, and to understand the nature of the way that data can be processed. I don't mean everybody has to understand how to write an algorithm or build an AI system, but to understand what it means for an algorithm to process data. And then finally, but very importantly, the why. Why are we using the AI to do this? Now, that example that you gave is a great example, because it would be very hard for humans to do that, because it involves looking at a lot of different data and making decisions and pulling lots of different information together. So I think it will definitely increase the likelihood of that. It won't be, the acceleration pace, I'm sure, was slow, but it won't go backwards, I don't think. But the thing we have to grasp hold of is making sure that both in the education that we provide for professionals, that real understanding of data provenance, the ethics of it, why data is so important for machine learning, some of the issues that can go wrong when you don't have the right data, or you have biased data, or biased algorithms even, because of course the ethics piece is extremely important. But I think there's also an opportunity here for the patients too. And I was thinking that when you were talking about the wearables, I think there's a huge opportunity if we can increase the acceptance that these technologies can be helpful to help increase the appetite amongst patients for understanding more about the data, and to start to develop an interest in this, which will be fundamental to really making use of helping people to get the most from remote monitoring, the most from wearable technology, when they can use the information to their own benefit themselves, as well as helping the healthcare professional to do that. I think there's definitely a huge step forward, and we mustn't, lose that advantage by failing to ensure that the professionals understand enough about the algorithms and the data for the use of those algorithms to be interpretable, because that's the word you use, Lionel, and I think you're absolutely right. In order for anybody to interpret what the AI is producing correctly, they do need to understand, to a certain extent, what is going on with that algorithm. As I say, not in detail, but they need to understand enough about the data, enough about processing, and enough about the why to really understand. Because there have been instances in the past where data, the AI can get things wrong. And so we need the professionals to feel confident enough that they understand enough to actually say, hang on a minute, I don't think that's right. So yes, it's been great, and I'm definitely gung-ho, and I'm not being a damper, as Henrietta said, but I just think it's really important that we don't lose sight of the importance of that educational imperative, and that we make sure that people are prepared to interpret, as you put it, not to allow the AI to take over and be the autonomous decision maker.
I certainly think that training is very important, because in some ways one of the problems about AI and machine learning, as well as great strength, is you can go onto the web, download a package, which is pretty easy to use, acquire or use a data set that may even be in the public domain, and away you go. And of course, that is fraught with huge dangers. Therefore, people need to be trained. It's almost too easy now. People need to be trained in how to use and how to interpret the results. And the interpretation you're talking about is very important, because one of the reasons people have been reluctant to use these models, these algorithms in healthcare, is that they're opaque. They don't tell you why they come to a certain decision. And so there's a lot of work going on now explainability and interpretability of algorithms. And now that we're getting them used in the clinic, in the hospital and so on, I think that can only grow. I'm going to ask Patrick to say something about this, maybe Elizabeth from the perspective of the patient, and then Rose to have the last word on the topic.
Well, I was also going to suggest Berne may just want to touch on the role of the bioinformatician, because I think for me, the next 20 years, data becomes king in the way that we run health services. And the sooner we can change the ethos of the way we train individuals to realize that their professional responsibility for the data that they have and use in healthcare, and that has to be in both undergraduate and postgraduate courses, and it becomes a major patient safety issue for everybody. For me, that's quite critical. But I am very struck by the role of the informatician and the bioinformatician in terms of what they can deliver for the future, and working with clinicians to bring about quite a marked change in the way we deliver health services. And I think Berne may want to just touch on that briefly in terms of what they're doing in the health school science.
Yeah, I completely agree with you, Patrick. So we are training these bioinformaticians, and we've been training them in HEE in the National School of Healthcare Science for the past 6-7 years now. So we train bioinformaticians who are clinical bioinformaticians, so they're also very important for the entire system. We train genetic bioinformaticians who will analyze all the data from the genomic sequencing. And we train bioinformaticians to look at imaging as well. And so so these guys are able to really deal with this a phenomenal amount of data. But we're also teaching them a lot about communication. We're trying to teach them that they've got to keep. And I often say to them when they all come along for the very first day, I say, the fact that you're a very good scientist is a given, but what you also have to be, guys, is really good communicators. And a bunch of scientists look at me horrified, thinking, oh no. But I say, no, you've got to be able to communicate. And we're teaching that, we're embedding that into the postgrad, and also we're trying to embed it now as far as we can of influence into undergraduate programs as well. And the other thing I'd say is that these guys are so well skilled that we're now beginning to have to do some work with industry to make sure that they stay in the NHS, because the moment that they are produced and delivered to the system, and we're training them for the NHS, they're just nabbed, they're just taken up by other people. And so we're actually having to work with industry to say, look, you work with us, but don't take them away from the NHS, we'll work with you instead. So I completely agree with Patrick. This group of people are becoming more and more and more important. And just the last thing I'll say is that the other thing that we're doing in the National School of Healthcare Science, and it's funded through Health Education England, is that we're developing suites of really short modules, not just for all around data science and around bioinformatics and around genomics, so that people like night nurses, pharmacists, medics, who lots of physios who want to understand this, who understand exactly what you said was the importance of understanding data. They don't have to be experts at it. We're delivering very short, sharp modules for them to take so that they can use them as CPD or as credentials as we go forward.
Thanks very much, Berne. Elizabeth, before I give the last word to Rose, please.
Yes, I think this is a very interesting one, because I think I'm not alone in hoping that I don't have to understand all this stuff as a patient, but I would like to be very confident that someone else does. And I think we need to have a very bespoke quality assurance methodology for this section of healthcare delivery, and so the public will then be confident that someone has sussed it out, basically. Because with other high-profile problems in different sectors, algorithm is not always a very welcome concept, and I think we need to recognise that and make sure that we've built a strong quality framework around it so that people are reassured.
Thanks very much. Rose, over to you.
Thank you. I agree with all that's been said. But I actually think, Elizabeth, it's our responsibility as AI scientists, to help the public understand it much more clearly. I agree with everything you say about quality control and regulation, but I really think we have to help people understand what's happening to a much greater extent. Because as Patrick said, data is key now. It's not just becoming key, you know, in many aspects it is key. And we need to really help everybody to understand why. And just as you've said, Lionel, they need to understand that it's not about downloading a data set and an algorithm from the internet, although that's quite useful if you want to play around, but actually the quality of the data matters. And how do you know if it's good quality data? You know, the way the data is processed matters. The imperative for using it matters. So I think we really are moving into a space where we have to help people wherever they are in this thread of ensuring the best healthcare to understand enough to really benefit and to feel safe in the way that they're benefiting.
Well, thank you very much indeed, and we're coming to the close of this roundtable. We haven't really discussed how the pandemic might have impeded, in whatever way, the implementation of digital healthcare outside of COVID-19. But because these are really difficult times for the NHS at the moment, I think it's good that we've concentrated on the positive for this roundtable. And undeniably, as we've heard, the acceleration of the deployment of remote monitoring and apps, wearables, genomics, AI, and machine learning, in many ways, the recommendations and the work that was done by the Topol Review are even more relevant now, 2 years after the report was published. But I'm going to ask Patrick and Henrietta, who helped us to begin this roundtable, to help us to finish with some brief remarks. Patrick and then Henrietta, thank you.
Well, for me, it's great to see everybody again, and really grateful for people joining in this conversation. I'm comforted that everything that's been said is certainly on our agenda within Health Education England. We're working with our partners in NHSX and other parts of the NHS. So for me, it's great to hear we are in the right direction and continuing to move things forward. And I have to say, it's also great to know, because I've had feedback, that the Topol report has moved into other parts of the world. And I know certainly in New Zealand, Australia, the Middle East, Canada, people have been using the report themselves to shape their own thinking of the impact of digital technologies on their own healthcare and care workforces. So it's really a great testament to the work that we did 2 years ago. So thank you. Henrietta.
Yes, no, really good to have you all again on the same in the same conversation. I think for me, it's a lot has been done. And of course, the review highlighted certain areas which we are beginning to make some real traction in. COVID, certainly for all its faults, has definitely given us some real opportunities in terms of our workforce beginning to appreciate what digital can do for them, rather than previous conversations where it's been, how can you utilize this digital? It's now a conversation of what can digital do for you. There is still a lot to be done. And I think, certainly within Health Education England, the digital readiness program has got the mechanisms and the infrastructure in place to carry on with this work, working widely with system partners to ensure that we really are making the most of the recommendations out of the review. So looking forward to what else we could do in the next few years or in the future.
Thank you, everyone. It's been most enjoyable to be involved in this roundtable, and maybe see you in 12 months' time, or possibly 3 years' time, for the 5-year review of the Topol report. Thank you, everybody.